Hey, Ashley, how are you doing?
Oh, how are you?
I am so well. So we are waiting for Dr. Jessica Shepherd to come on. She's having some technical difficulties, so me and Ashley will be here in the interim to engage with you all. If you guys have any questions for us, feel free to ask them in the chat. We can respond to them. So, Ashley, are you enjoying GlamCon? I know this is the first time of us doing this virtually, but it's been amazing so far. What do you think?
It's been awesome. I think this is so much better in the current climate of where we are, just to be able to enjoy. Probably even better for some. So if you're not feeling well, you don't have to worry. You can watch from your bed, watch from your couch, listen in your car. So I think it's an awesome way, and I'm glad that we were able to transition instead of saying, we won't have any event, that we can still reach the masses. We can still come together and encourage people, have a gathering, a sense of community in a time where we're kind of all staying to ourselves. So I think it's awesome. Great experience.
Yeah, absolutely, absolutely. I agree. First and foremost, we want to make sure we protect the health of everyone. The times are very uncertain, but I'm glad that we could still be here and join in together as sisters and enjoy all the amazing speakers and what they have to offer today, and so we can all revive and restore. I know some of us have been feeling kind of sluggish these days, and maybe I'm just speaking for myself. I
No,
know I've been feeling a little sluggish these past few days, but I'm so excited to be here. I already, was able to, get some meditation in, and now, creating some amazing affirmations, and now I can learn about my body. I know you have a personal experience when it comes to fibroids, and that's what our conversation is going to be about. We talk about the other health issues, but women, it's a lot when it comes to us. We go through so many different things, and a lot of them are unexpected. And so Ashley is someone who has actually had an experience with fibroids, and we are so glad that she is able to overcome, and she's here with us today to share her story. Can you give us some, a little bit of background, Ashley, on your story and where you are now?
yes. So kind of today, my approach to talking with Dr. Shepherd is as a moderator to say, okay, here's some things that I think women want to know, but also as someone who's gone through it and someone who's still going through it. I was diagnosed with fibroids after really having to essentially regulate my physicians and say, something is not right. I kept being told, oh, it's nothing. I didn't have all of the symptoms. I really only had one major symptom, which was heavy bleeding. So all of the other things that people were saying, like, oh, I have extended periods for 2 weeks. I'm having a period out of the month, or I'm having such painful periods I can't go. I wasn't having those things, but when I was having a 5 to 7 day period, I mean, it was excessive, like to the point where I was like, okay, I'm full blown hemorrhaging. And so they were like, oh, you're almost 30 at the time. It's your hormones and all these different things. And so I just can attest to the struggle of trying to be heard, and then the struggle of trying to find the proper physician for you. Once did get it confirmed, had a scan, and they're like, okay, there's a fibroid. There was the initial shock of, oh, I have this fibroid. And then my doctor was like, all due respect, I'm going to turn you away. I don't feel comfortable. And essentially, I'm grateful for that, but it just opened up more struggles and things I just didn't know. So that's what I want to bring to the panel today, is being able to ask questions from someone who has gone through it, and then someone who had the surgery. And unfortunately, I searched and searched for a doctor, and the doctor did not handle it well and ruptured. And now I'm someone who has full spectrum view. Now I'm someone who needs to have another myomectomy. I'm someone who is trying to salvage their fertility. So just trying to bring that in, so there's other people who are struggling, or other people who are saying, you know what, something is not right with my body. I don't know what it is, but my doctor is saying one thing. I don't think that's quite the same. I always say a doctor, they specialize in medicine. They specialize in cases that are reported, but you specialize in yourself. So if you know something is not right, get another opinion, go elsewhere. Don't just say like, oh, they're the specialist, they know everything. They're still learning. fibroids are something that affect so many women, but there's so little known about it. So I feel like, you want to take the guidance of a physician, but if you know something isn't right, like I for sure think people should learn to advocate for themselves. So that's kind of what I'm trying to bring today, is like questions from someone who has gone through the journey and is still very much so in the journey.
Absolutely. That's some good information. And I would just want to reaffirm that you actually you have to advocate for yourself and be proactive when it comes to your health. And if you feel like something's not going right and you don't trust what your doctor says, and it's always okay to get a second opinion. So make sure you think about that through your overall health. Now, I got some good news. Dr. Jessica Shepherd is here, and we are getting ready to bring her on here. Hey, Dr. Jessica, I'm leaving you guys chat.
Okay. Hi, Dr. Shepherd. How are you?
I'm doing great. How are you?
Well, thank you. Uh-oh. Can you still hear us? Okay.
I can still hear you.
Okay.
There we go.
Got it. So
I'm having like major tech.
Okay. Hey, but we're good now? Okay.
Yep.
So, all right. I was just talking and kind of going over what I wanted to bring to the panel as someone who has dealt with fibroids before, had a myomectomy, and it just did not go well. And now I need to have another myomectomy to correct things. And someone who is now their fertility has been put in jeopardy. So just really some questions. And from that, as someone, not just a moderator who's like, oh, give us some facts, but someone who's in it and really give some specific questions. So I don't know if you had any further introductions you would like to make, or if you would like to get started, whichever you would prefer.
Yeah, let's get started. But since you were talking about your personal journey with it, what didn't go right with the first one?
The first surgery, we said, we're going to do it hysteroscopically, go in, because it was submucosal. It's sitting like right inside the uterus. And so I think that's one thing people don't know. I feel like the uterus, like it can be prime real estate. So depending on where the fibroid is determines what your options are and what's going to happen. And so we went in, and later in my own ignorance, just not knowing, at that point, it was when I first went to the doctor, my doctor, when I got diagnosed, said, you know what, I'm sorry, I'm not going to operate on you. You do have a fibroid. I don't feel comfortable. If I were to operate, the only way I know would essentially kill your chances of fertility. And so I searched around for different specialists, and I went to what was supposed to be the best in the area, and just didn't have, feel like I wasn't being heard. I was saying things, I was taking these images, and he just was not hearing me. And so I ended up flying out elsewhere to go to a surgeon that I heard good reviews about. So I was like, okay, I'll try. And even initially when we talked, the fibroid was over 5 centimeters. And learning later that hysteroscopically at over 5 centimeters, your machine's going to run out of fluid. It's calcified. You might have issues, just a lot of things that it's not realistic to say, oh, we're going to be able to get it all. By the time I got there and did my pre-op appointment, it was over 7. And she's never said, oh, you know what, there might be issues. And so we had the surgery, and she ended up puncturing part of the intestine, but unbeknownst to me. And so not getting the proper aftercare and saying like, oh, you know what, I'm feeling having some issues. And she was like, oh, no, it's fine. You're fine. It's no big deal. And only to turn around later and have a day where I was like in such pain and had 2 abscess that had formed internally. And so at that point, I had gone into severe sepsis, had emergency surgery, 1 abscess ruptured. I guess that was what was causing so much pain. And that damaged a fallopian tube. And so just a lot of things that in my own ignorance, like just trying to figure it out as I go along. I spent so long trying to get someone to even diagnose me, say, hey, something's really wrong. I'm having these issues, because I was only having heavy bleeding, but not necessarily prolonged bleeding. Like that delayed my diagnosis until I got to the point where I was really like, okay, somebody's going to test me. Somebody's going to give me an ultrasound, something is not right. And so just trying to encourage ladies to really advocate for themselves, because like I said, doctors, they're specialists, they go to school, these things, but it's also by case study and there's so little known about fibroids. So if you suspect something, you really have to push and say, you know what, then maybe I need to get another opinion. And because sometimes time is of the essence, right? You don't know how quickly it's growing. And so that's just something I want to encourage. I feel like if I have a struggle and I overcome it, then I can help someone else and they should have a different struggle. They shouldn't have this struggle. And so that's kind of where I'm coming from today with the questions.
I think that's great. I think one of the things also too is every individual story is different. So your story is different than someone else's. So, you know, what I'm hoping that I can give today is understanding of the process and the journey, because everyone's journey is so different. Now,
Right.
fundamentally, there are things, and foundationally, there are things that are going to be the same when we think of fibroids, and pathologically, and how we can make those better, and what expectations and outcomes are. So that's a lot of the things that kind of sometimes it's hard for doctors. We maybe don't do the best job of what we're actually sorting through in our head as we go through that process, because there's so many touch points when we think of fibroids and heavy bleeding. And then everyone's
Right.
expectations are different too. Some people are like it's a fertility thing. Some people like it's a bleeding thing. Some people like it's a pain thing. So it's kind of like we're trying to do a flow chart for everybody based on their
Right.
different, expectations. So I hope that the questions that we get today will be able to kind of shed light on those.
Yeah.
Again, with the understanding that everyone's little house of fibroids is so different.
So different. Yes. So starting out, I know studies, we're still kind of figuring out numbers, but roughly 60 to 80% of women are said to have fibroids at some point in their life, whether symptomatic or asymptomatic, and they don't even realize it. But I feel like now it's gaining popularity, but so many still don't know. So can we start off by you explaining exactly what fibroids?
Yeah, so fibroids are actually the most common benign tumor. So they're benign in the female pelvis. So when we look across the board of any race, Asian, Caucasian, Hispanic, and Black women, that statistic is going to be about 50% by the time they're 50 will have a fibroid. Now, it doesn't necessarily mean that it's symptomatic. It could be very small. We're just literally saying, if we were to do an ultrasound of your uterus, would you have a fibroid? Now, when we bring that to African American women, that is going to jump. That's going to jump to about 75 to 80%. But again, this doesn't mean that everyone is symptomatic. When we look at symptoms and like who is really having, whether it's a difficulty or not even from a symptom, it could be anywhere from 25 to maybe 31%.
Okay.
So it's in that percentage that we're usually focusing on women, because the other thing that we have to consider, and that's why, women may come in and be like, I have a fibroid, is we really want to sort through those symptoms, because then we may be giving medication or surgery or procedure to every woman who has a fibroid, and that's not our intent. Our intent is really to deal with women as they're going through it, and it's starting to impact their quality of life in some way.
Mm-hmm.
So that's where we're going with that 25 to 31%. And then when that becomes an issue, I think it really is, like you were saying, what that conversation is and how that conversation continues, which really helps women understand, what do I want out of this management? And what am I trying to accomplish in the future?
Mm-hmm.
Or what are some things that I'm not really willing to give up at that point? So those are the conversations that, I think that patients and women can have better touch points as far as advocating for themselves. Because many times the management is going to be so different for everyone that it may be hard for people to understand why we offered an option to one person but not the other, because there's so many different factors. Mm-hmm.
Understandable. Okay. And so I think you started touching on that, but I think one issue that many women deal with, I even dealt with myself, is getting proper diagnosis and saying, because symptoms are so varied. I know so many women who've been like, oh, I had horrible pains, and they check off the checklist of things that you would see if you look up fibroids. And when I was saying like, oh, I'm having this bleeding, I couldn't really find anything other than heavy bleeding, which can be caused by a number of things. So what exams and scans or tests or things do you think women should be asking for if they suspect that they have fibroids? Where should they?
That's a great question. For me, maybe because I am a Black female physician, I think one of the easiest ways to really get an answer from a clinical standpoint, so I can shed light on it, is an ultrasound. They're relatively relatively inexpensive when we think of like cost of medical care. That's why, I don't say, oh, get an MRI. That's a completely different thing. That may follow an ultrasound, but I think an ultrasound is a really good way to see, one, if you do have fibroids, but also I also like to use it as a baseline. So when I say baseline, I mean if someone comes in and they have a symptom and they're like, I have really heavy bleeding, and I say, you know what, let's do an ultrasound as a baseline, because in a few years, if something changes or you start to have now pressure or you start to have urinary issues, and I repeat that ultrasound, I can now use that comparative ultrasound to your baseline, like us present day and what we're talking about and what's impacting, your quality of life. And then I can compare it, because it may not mean that I'm going to do something in that current stage if there's nothing really for us to do, but it's a good baseline.
Right. Agreed. And I think that's how I started, was an ultrasound, and then later sonohysterogram, and then a hysterosonogram. So yeah, I went through the stages. When I was trying to get to the root of the problem, and I was speaking about heavy periods, I would speak in terms of, yeah, I use so many sanitary products this size and this amount of time. And then later, after I had my emergency surgery, I recall them saying like, oh, you know what? When I went to the emergency room, I was like, I've never been in the emergency room before. And I was trying to relate kind of how I felt. So I said, oh, I've had ACL reconstructive surgery and other things, and I think this is hurting like that. Like, I was trying to find ways to speak and say, like, I'm actually in pain. Like I said, I'm in pain, but I usually don't use the term pain. So I was like, well, that's really relative. They don't know. And so when women are speaking to their physicians and their doctors, what rhetoric and reference points do you suggest they use when they're trying to describe the pain or the bleeding, et cetera? Like, what are proper ways to communicate that?
That is probably, if there were a takeaway from this entire panel, is how to quantify or qualify those particular touch points that can resonate with us. Because many times, and it's not to the patient's fault, but in a physician's head, we're like, this is very frustrating, is when patients come in and say, I'm in pain. And we're like, pain like
exactly,
or you stubbed your toe. So, one of those things that really helps and get like an effective visit is exactly what you just said. I've had my ACL torn, and I feel as if that level of pain that I had at that time for me is similar, because pain is subjective. So just using the word pain is like,
it means nothing.
So like it becomes this standoff in the office, and I'm like, pain, like bad pain? Like, we need to know, for you as a particular individual, what does that really mean to you? For example, I've had people who are like, I'm really in excruciating pain. And they're like, but I've birthed 5 kids with no anesthesia. And I'm like, well, that sounds very painful to me. Is this worse than that or better? So, coming in with comparatives always helps. When it comes to bleeding, I find the best way to, because you may be bleeding heavy, there's that, but that again is different. So for you may say, I am going to the ER because I've never bled this heavy. There are a lot of people who are very uncomfortable because it's vaginal bleeding, and maybe that makes them feel uncomfortable. They'll go to the ER multiple times, and it doesn't necessarily mean that they needed a transfusion. So then there's that. I'm like, yes, you went to the ER, but it wasn't critical where we had to admit you and get a blood transfusion. So in our head, we're like, it's outpatient management, so it wasn't that heavy. So that's also a good parameter. For me, what I find is how does it impact your quality of life? I had to miss work, or I was at work and had to leave because I soiled my pants and got the seat wet. Or, I was on vacation and we weren't able to do anything because I bled so heavy. Those are kind of the things. Quality of life factors is another great way to relay a story and have us be able to extract from that and say, this is that qualitative or quantitative factor that will help me make a better decision as a physician in the management of how I can help you.
Right. Okay. Awesome. Yes. Agreed. Very much. The next thing I talk about is, as fibroids, I feel like we're kind of developing and we're learning more and more about this. But one thing I've seen consistently is that estrogen increases fibroids. And so what ways women work to balance their hormone levels and reduce excess estrogen medically and
So I think those are one of the things. So when we now dig down into studies like bench research, like really high level research, and we look at those factors on how they actually impact fibroid growth, we know that there is an impact from hormones and somewhat from the substrates of estrogen and progesterone. You know, progesterone too, as well, can be contributory to the growth of a fibroid. So one of the things that we do know is it is an impact, but it's not one of the major things that we would say, oh my gosh, we have to balance your levels of estrogen and progesterone in order for you not to have this outcome or the growth. Because here is why. Every individual has a very different level of what their estrogen is. Or there are different types of estrogens, and there are those that are like very growth prohibitive. And then there are those that really push growth. So it's very hard to pick one person out and be like, well, this is the type of estrogen that's contributory and yours is higher. So then this means that.
yeah.
So what we really want to impress upon women when we think of hormones is more so you can actually control more of the hormones in your body by the ones that may be outside of that range that are contributing to growth is really lifestyle factors. Decreasing inflammation, one of the things we do know, and that's why we can link obesity to fibroids as well, is because tissue in your fat actually creates estrogen. It actually converts to estrogen. So the more tissue that you have that's in fat tissue, it converts to estrogen, which is now going to give you more than what your normal underlying level of estrogen is. Also, the foods. So I'm going to say this very cautiously because I know that there are a lot of programs out there that pander to, if you eat this particular diet, then your fibroids won't grow. I do not advocate for those diets because one, quality of life, they're very not sustainable. Like I always tell my patients, I can't travel with you ever because we can't eat together.
Can't be away from
you can't eat and
exactly.
And I really want people to take on a quality of life that they can sustain till like they're 60 and 70. And very few of the patients who have done those diets have been able to sustain them for like years and years and years. And just to give you an example, I will always remember this patient. This was when I was in Chicago. This was a patient who was vegan, like for a long standing, not just recent. She was very athletic, very slender, had natural hair. Because I know there's, people say, is a perm gonna. She had like all the things that you check off that, and she had the largest fibroid. So then I was like, you've defied everything that everyone would say this is a cause of being fibroid. So that's how I know it's so multifactorial. And we can't just be like, there's this one thing that's going to cause a fibroid to grow. It's very DNA related. And that's where the research comes in. And that's the research that we don't have. That's what gets me angry because it's a Black woman's disease, and women's health and Black health to me always fall on the back burner. And that's why we don't have that fundamental research that would tell us this may be the gene that contributes to fibroid growth. And if we knew that, then we could make so much more strides in medications or, finding, do you have this gene? Therefore, are you predetermined to possibly have very large fibroids in the future? So I think that there are things that we can do: lifestyle, healthy lifestyle, exercise. I'm a big proponent of exercise and eating healthy to decrease the levels of inflammation in your body. That can be very contributory to fibroids and what we can do individually.
Okay, awesome. That was a lot of information.
That was very long-winded. I'm sorry.
No, thank you. The next I'll say, there are multiple options for dealing with fibroids, and of course, case by case, as you talked about, your end goal. And so, discuss some of those options and highlight ones that are trying to salvage their fertility. And I only ask that just because sometimes, if you're not looking to salvage your fertility, you almost do anything you would like to do.
Right.
If you're not to favor one group over the other, but for women who are looking to, because they're still at one point following emergency surgeries. A doctor told me, like, I think you should just have a hysterectomy, freeze your eggs, have a hysterectomy. That's really your only And I mean, at 31, I mean, I was devastated. Like, that's the only option. And yeah, 30, this was last year, 31. And I was like, that's my only option. And he was like, yeah, you know, and he was very sincere, brought me in his office and was like, this is the option. And I think this is the best way. I'll refer you to a well-known fertility specialist out here on the East Coast. It's really well known, good. And I went there and the doctor, like, Ashley, you know, couldn't even mark me infertile on my chart. I think there's other options for you. I cannot attest to why this doctor would do that, but I mean, just knowing if someone has been in the journey and they're tired enough, you know, you just get so discouraged that you might be like, this is my only option. And that's what I want women to say. There's nothing against hysterectomy, nothing against UFE. There's nothing against anything. Whatever is best for you, best for you. But I just want women to know that there are other options. And just because one doctor says one thing, no matter how serious or how passionate about it they are, you can always see if there's other options. So I just want to know if you can talk about some of them.
No, I think that's so important. One, you're not the only person I've heard that from. It's still very baffling to me when I hear that, because I'm always like, are you sure they said that? And they're like, yes. So one, I feel that yes, hysterectomy is not always a bad option, but before I would ever just say this is the best choice, I would list the things that are optional, but with the caveat. I would say this is still an option for you. However, it may mean this in the future. This is an option for you, but this may be some of the outcomes you expect. Because I feel the more educated that women are, then they can make better decisions and informed decisions for themselves. Very few patients have I had where I've had to say, I don't think it's your only option, but it might be the best option as far as a hysterectomy. I can count them probably on one hand. And I've done tons of surgery. I probably do about 100 to 150 surgeries a year. And I've been doing this for over 10 years. So if I can remember those 5, that means there was something imperative, whether it was probably more critical to their health as far as like more life and death factor, that I was like, listen, we're kind of like holding on by knuckles at this point. We may need to consider this as your option. But when I think of options of fibroids and or heavy bleeding, I always ask my patients, before I start down this road of options, what are your ideas for starting a family or fertility in the future? Because to me, that helps me knock out the ones that I can't offer them because it may prohibit their, you know, childbearing or fertility at that point. So I think I could go through all the options. That's probably not the best way to answer your question.
Right.
The way to answer the question is to always advocate for yourself and say, here's what I'm trying to do in the future. How can you help me get to that goal? But also as a patient, being realistic with your journey and understanding, yes, I know I've had 5 surgeries before. I may be increasing my risk of not great outcomes, but still tell me what that means for me.
Right. Exactly.
And, you know, saying, well, my friend had this and she had that. That's not the good way to go in either, because you are your own story and your journey has been different.
Agreed. Awesome. Thank you so
much. Thank you. Hey, Dr. Jessica. Thank you, ladies. We'll be going over to our next segment. Hey, sis, are you good? So let's go over there and we'll see you in that group. Bye-bye.